thanks so much for joining us for our next session. I'll be chairing a session. I'm Shafi Ahmed, co-founder of Giant, and a surgeon who worked at the Royal London Hospital. And it's going to be a great pleasure to take this panel through a few questions. And of course, it'll be open to the floor as well at the end. So please do think about what question you might ask our esteemed panel here at the end of our conversation. So I guess to put it in context, as I mentioned before in my opening earlier yesterday, the NHS is facing some serious challenges. We know that, right? We've got serious workforce shortages being highlighted. We've got the perennial problem or annual problem of the winter crisis coming up ahead of us in the next few months, with COVID now just obviously taking its role in producing lots of issues for us in terms of going forward. In terms of waiting lists, we have over 7 million people now waiting for a surgical operation, and we're not sure how we're going to fit those in over the next few years. We've seen people now being delayed through cancer diagnosis over many years because of COVID. We've got a huge backlog of patients with advanced disease. A lot of people now wait for operations. So there's a lot to be done, a lot of challenges that we're facing. And hopefully our panel here can offer some solutions and some ideas about how they've been involved in solving some of these problems. Of course, as part of the ICS show, the integrated care systems are new. How does that work? We can try and figure out with our panel here, because they will need our support going forward to create an economy that allows to improve patient outcomes and create a value-based healthcare. So a lot of things going on together, and hopefully we'll unravel some of those mysteries with our panel. Without further delay, I'm going to ask them to introduce themselves to you before starting the conversation. So Gus, on my left.
Hi, Shafi. Gus Meyer. I'm a senior partner at Deloitte. I head up our UK healthcare practice, specialising in technology and health.
Showing the strategic alliance there. Anne-Marie Weinlott, so I'm head of Centre for Health for Vodafone.
Priya Kumar, GP from Kumar Medical Centre in Slough and Health Inequalities Lead.
Hi, and I'm Paul Moback. I'm the strategic advisor on ICS collaboration across the NHS Midlands.
Great, thank you. So great array of people from different parts of the healthcare service. So I think I'll start asking Gus a question. Gus has been involved in a lot of transformation, of course, in his role as Deloitte, but it's a broken system, we all think. And sometimes we've got to go back to basics before worrying about technology innovation. So how do we fix the basics, Gus?
Well, first of all, I think the NHS is one of the most innovative healthcare systems in the world. They have some absolutely fantastic clinicians who've come up with some great ideas. The thing for me is about scale and access to that scale. We have not been able to scale much of this technology system-wide or across the UK. And I think a lot of that is around about the foundations. So if you look at much of the technology we have in the NHS is analog. It's about 10, 15 years out of date. And we're making the migration towards digital technologies. So there is a journey, but that journey is up to 5 to 10 years. And I think we do need to sort of look at how we can radically transform our healthcare services, but at the same time, we need to look at that digital infrastructure that we need to build on. And once we do that, I think we can scale a lot of these solutions. And the combination is also jointly working with public and private sector, and seeing that collaboration as a really important collaboration. I wouldn't think about doing medical services tomorrow, but, I know the clinicians are fabulous, but there are many NHS organisations looking at developing tech businesses, a whole range of things that actually probably aren't in their comfort zone and haven't got all the infrastructure to be able to expand those out. So collaboration is fundamental, but in principle, it's just getting the foundations correct. If we don't get those foundations correct, we cannot scale the digital healthcare system, which I think is vital.
Thank you for that. And actually, coming to you, Anne-Marie, at a topical moment, Gus mentioned getting the infrastructure right. Yes. I guess that's where Vodafone might come in, to support the kind of the frustrations we have around connectivity, etc. What are your thoughts about that as Vodafone?
Yeah, so absolutely 100%. Being able to align those systems, if I had to say one of our biggest challenges, it's actually coherence. And you know, we've got IT landscapes, multiple different baselines. I'm looking at Paul's sort of wry smile as I say that. But being able to really bring those together through collaboration, both with the private and public sector, but within these ICSs is hugely important. And that's really how we're going to step forward and really address some of the patient pathways and the demographics within those local areas.
Thank you. And Priya, coming to you as a practicing clinician at the front line, and you, of course, very much the front line during COVID. GPs seem to be doing all the work for us, and thank you so much for the hard work that you did over the last 2 or 3 years. But also you're involved in innovation, I understand. Give me your thoughts around how we kind of get the basics right, and how we're moving on from COVID.
So we've come a long way through COVID, as a lot of the red tape was taken away, and we've integrated our systems. We're very lucky in Frimley ICB. We have the connected care, where we have an integrated system through primary, secondary, and social care. But really simply, as I'm a GP, I can see my patients sitting in A&E. I try to ring them, I can't get through to them. And it's simply simple things like 5G we don't have. You know, we have the systems in place, but that data isn't real time to us as clinicians to make those decisions. So interestingly, we've kind of gone advanced without actually thinking about the really simple things of connectivity. And that's from the professional facing kind of element, but even for our patients. We're creating digital solutions for our patients, and some of them don't really have accessibility. So we really need to think about that as well.
Yeah, and so the other thing to think about is this kind of evolution of a healthcare system. We go through changes every 5 or 10 years, and I've got a new one called the ICS. So what I'd love for you to explain, if you can, what ICS is to some of our audience who may not know what it is, and what you're thinking how that might help us as we go forward to develop a health service.
Okay, thank you for that. Integrated care systems. Well, basically, it's bringing together all of the organisations within a place. So there are 42 integrated care systems across the country, and it brings together all of the providers together with local authorities and other interested groups from local community together into one coordinating group. All the individual organisations are still separate organisations within integrated care systems. So one of the challenges for ICSs is that they're dependent on those organisations then wanting to collaborate with each other, which is where my work is at the moment. And it's quite a challenge because the NHS traditionally has been organised around individual organisations and the responsibilities of chairs and boards and chief execs to deliver for their own individual organisations. So now coming together in integrated care systems, everyone's starting to have to change their mindset and say, actually, how do we collectively work together? But the benefit for this for the patient is that actually that brings together all aspects of the system together, so all aspects of actually how patients might interact with the service, and requires the kind of organisations that are delivering for that to actually work out solutions together. So that's where the opportunity exists. But at the moment, I would say that if you turn on the news today, and you mentioned it at the start, there are some really fundamental challenges which come down to at the moment around capacity, both. It's often described in terms of bed capacity or bed capacity in the wrong place or workforce capacity. And I think one of the things that ICSs are grappling with and haven't yet got their kind of, you see examples of really good practice in here, but as Gus says, it needs to be done at scale, is we need to start thinking differently about how we understand our capacity and resources and how we understand the best way to utilise our workforce. And I think it's that unless we find solutions to make better use of our workforce and think of our capacity in different ways, then you're going to continue to see the kind of headlines that we have at the moment where ambulances are outside the A&E.
Yeah, I think you're right. It's about being smart, isn't it? That's the key word that we're learning over the last few years. And thank you for also bringing the patient to the conversation, because we often forget that when we get to conferences. Actually, there's someone benefiting from the work that you're doing, and that should be a centre part of our discussion as we go forward. Priya, talk about patients, Priya. Now, you've done some incredible work during COVID, which I was really amazed at what you've done. Can you share with the audience about real-life scenarios where you've innovated at scale in a general practice and in population?
So it's just going back to what Paul was saying. It's about using our resources really cleverly. So through Connected Care, we understand our population as a whole in Frimley. So we have 850,000 patients. We could see all our patients that were COVID positive. And we basically set up remote monitoring. We were one of the first national pilots to go with the Pulse Ox program. And what we could find out of those that were positive, we found the 6 people that lived on their own. And they were the most high risk. And therefore, we ensured that they were enrolled in the Pulse Ox program, not a referral from the GP. We found them within the data, and we could support them in a different way. I mean, even during the conference today, we're doing a fuel summit in Frimley at the moment, and I've just received some data. So we have red patients in Frimley, where these are extremely frail patients. We've used the Johns Hopkins segmentation to understand our patients and their baselines. We have about 3,000 in Frimley. The data we have, we've basically connected with the energy companies. About 724 of those live in EPC levels D to F, and then 124 of those live on their own. So now we're thinking as Frimley and ICB, let's use our data to support those 124 that we know have respiratory disease, we know they have heart disease, we know they're going to be cold this winter, but actually try to sort out the wider determinants of health to basically support their health outcomes. So if they get cold, they'll end up getting an asthma attack or their respiratory condition, and they'll end up in our A&Es. So let's start to shift everything to the left. Let's start being preventative. Let's start using our data really cleverly to really start to support our patients in a completely different way.
That's great. And what you're describing, of course, is the whole concept of data-driven healthcare, personalization, preventative medicine that we've been discussing for the last 5 years. But actually, during COVID, you put to clinical practice now.
Yeah.
Yeah. Targeting populations, right?
Absolutely. COVID was a catalyst for us to really start to do these things. And really, as Paul's saying, let's start using our workforce in the right way. And let's start to be smarter, like you said.
Yeah. And Gus, your work has been extensive. I'd love to get your thoughts on examples of being involved in the last decade or so on real transformation. I know you're working with some hospitals already in the UK. I'd like to get your thoughts on what you've seen as the challenges, how you've overcome them, and how you're supporting organisations along that kind of journey.
I suppose I'll just come back to what Paul sort of said earlier on around capacity. For the sort of last 20 years, I've worked with lots of organisations, and what they face is the today, the here, the now, the long backlogs, the long lists, and there aren't any new sorts of solutions at scale from my point of view. And if I look at the investment corporates make in technology, it's about 15% of their overall spend. If you look at the NHS, it's about 2%. So there's a big, big difference in terms of the solution sets. If you ask me about how I look at a problem, my first response is digital. I never put people first in that sense, because actually we need to do it very, very quickly at scale. So it's looking at those solutions, and I'll give you a fantastic example. The Queen Elizabeth Hospital had a backlog of nearly 12 months on their skin cancer, on their pathway. They introduced skin analytics, and I think they're here in terms of their technology, fantastic technology, introduced the pathway. They reduced the backlog within 6 weeks down to 0 wait. That's one example. So my question is, why can't we scale that across the NHS fully so we have no waits whatsoever? If one hospital can do it, a 12-month wait into 6 weeks, cut it down to 0, what's stopping us from putting it on a Google platform? It's integrated, push it across the country, bang, that's one gone. So when I start to look at these things, I do think we can, through technology, address many of these. And I think there's about 60 or 70 technologies that will come through on a pathway basis that will resolve that. And that's the sort of imagination and the sort of scale that I'm thinking about. To me, that then starts to address the issues about capacity, about workforce, actually freeing up more and more time of very valuable clinicians, nurses, doctors, support assistants. They're very, very valuable people. They have unique skills. So if we can free up their time to push back into healthcare, looking after people, rather than admin process, because there's a huge amount of process. And I think the mantra that Deloitte and Vodafone have is, can we reduce the overall burden by 20% and give that back to care? My firm belief is we can do 20% and more, but we have to look at solutions at scale. And the NHS have got loads of fabulous solutions. We just need to lift them up at scale.
Yeah, no, I agree with you. Anne-Marie, back to you about, I guess, Vodafone's role in innovation, in implementing change. I remember discussing earlier that Vodafone came very quickly to build the Nightingale Hospital as part of the consortium very quickly, and came and offered amazing contribution to build a hospital very quickly. I'll give you examples of what you guys are doing at Vodafone in a Centre for Health, but also in working with NHS partners.
Okay, so I mean, yes, Vodafone has definitely leaned in, if you like, to some of these problems, and I think very much recognise this as being now is the time to actually make that kind of digital step, because it's been so accelerated through what happened with COVID. I think in terms of how we're then leaning in, it is about first of all, from an ecosystem perspective, working with other organisations to actually understand what are they doing and how can we connect the dots, as it were. Gus has brilliant examples from across the whole NHS, bringing those together with things like the work that Priya's doing, and actually then taking some of that and really pushing it out there, and allowing all of us to fail a little bit faster. And I think that's something we don't allow ourselves the ability to do. So having come from a finance background, actually the business case that you have to develop is always about, I need the money out and I need it out now so that I can reinvest it straight away. But it doesn't take into account that actually someone else somewhere else in the country is already attempting to do these things. So where we see ourselves in this kind of ecosystem structure is in starting to, through our collective knowledge, working with different pieces of the structure, starting to connect those dots, and then also building on the connectivity piece that actually brings together, how do you take the data that Priya is capturing, put it into the cloud, actually introduce the machine learning, the security around it, all of those kind of concepts that keep it in a secure space. Because obviously there's different types of data sets that then get involved in this, from the direct care all the way through to the anonymized data, and that's something that we have to work with as part of this coherence in the system.
Yeah, of course, thank you for that. And actually, one of the things you mentioned about is technology, it's digital, etc., being some of the possible solutions. It's also a barrier. And I'll go back to what Gus was saying earlier and come to you, Paul, because in the sense that we've seen wonderful pockets of innovation. You mentioned Skill Analytics doing an amazing job reducing the waiting list to 0, but that wasn't scaled across the NHS. So it's always been a problem. Pockets of innovation, amazing outcomes, but not addressing the entire population. How will the ICS adopt that? So those ideas saying, can we do something much faster, much more wider? What are your thoughts about that, and how would we overcome those barriers?
So I think it's one of the challenges I think is that the NHS is a bureaucracy, and what we've got is a lot. If you take what's happening here today, you've got huge amounts of innovation, but the kind of way of working is so fundamentally different to the culture and way of working in terms of the way the structure at the NHS works. So ICSs are already looking at how they work together in partnership within their system. I think the obvious logical step is that ICSs also need to work out how they then work in partnership with large-scale private sector providers, etc. The experts, and ICSs aren't experts in digital, so they need to partner with experts that are, and then work with them to help to see how we can then, as Gus says, at scale solutions, how we can enable innovations to be drawn in to work with the service. It's only through partnership between not just within ICSs, but between ICSs and companies that and organisations that can bring that skill and understanding into the health service is the way. It's the only way we're going to solve these challenges, and it's the only way I think we're going to effectively do things at scale. I think at the moment, for a lot of organisations, it's quite challenging to understand how to engage with the health service. You might be successful with one individual organisation, but then if you've got a fantastic solution, how do we then roll that out across the whole of the NHS? That's a real challenge, and unless we find ways of creating these partnerships, I think that's the solution to that.
Yeah, and I think you're right. It's about collaboration, partnerships. But I'm looking at a metaphor here. We've got this barrier here, all the innovators on one side, and we're discussing the problems of the NHS. It's like really interesting as I'm staring at you across the hall there. Gus, more work around transformation. Yes, it's digital. The problems we have are barriers, adoption, change management. How does Deloitte overcome those problems? Obviously, I've worked a lot during my 3 decades in healthcare to understand better how we, as clinicians and healthcare workers, adopt change. That's been also a problem. What are your thoughts around that?
I think for me, to adopt change, you have to work with people. You have to work with the clinicians. You have to understand their problems, and you have to understand their language. So our first premise is to really understand our clients. We have clinicians, nurses who work on our side who really understand the sort of environment they work in. So firstly is understanding that. Secondly is also understanding the constraints. And there are many working in this sector, and they seem to be getting more and more exacerbated as we sort of move on, whether it's workforce, whether it's finance, whether it's sometimes the politics, the joining up of the ICB, rather than working as a lone island. Actually, the sector is now working together, which, you know, I'm very positive about the ICB bringing together, because then you can start to work on population level. So I think there are sort of many challenges that you can start to work on. The thing for me, moving forward, is actually, I think the current structure was designed about 80 years ago in terms of the health service, when life expectancy was probably about 50 or 60. So GP to acute was probably the only thing. Actually, these days, you know, if I look at sort of longevity and the study in longevity, people are looking at living well beyond 120, maybe 130, 140. So we need a different sort of system and a different design. And I think that's what Deloitte and Vodafone is looking at, is what are the intermediate steps over the next 10 years to start to redesign how we do things. And digital platforms are a very big solution. So in between the GP and the acute sector, actually there are several steps that you can design and build in that people can actually start to use more accessible healthcare. And you see it in other worlds. So we've got a fabulous GP booth in France where people can actually come in and have virtual consultations. They can book that in through a sort of central platform. They've issued, I think they've got about 2,000 in circulation in rural areas, in universities, they use them. Fabulous access to healthcare. There's online platforms. There's, in the Middle East, they've created wellness centers. So actually people with long-term diseases can go into wellness centers, as opposed to sort of our existing hospitals that are quite expensive to actually operate. So I think we need to sort of look at how we redesign our healthcare system that is very cost effective. This doesn't have to be very expensive. My personal view is actually what we need to do is move some of the resources around, and then we can actually create a very different healthcare system that allows accessibility and addresses previous issues around inequalities as well.
Yeah, absolutely. I think there are those solutions out there. We all see them. There's a great example of those taking away bricks and mortar from having little cubicles, if you like, across France. Yeah, we've seen that. Amazing. Takes away some of the expense required, thinking differently. Anne-Marie, from Vodafone's perspective and your own understanding of saying examples of what you've been doing and the use of 5G. Now, 5G came out, what, 3-4 years ago, perhaps around that time, offering a lot of promise around what we could achieve. What are your thoughts around 5G, cloud, edge computing? What can we expect to help us in the future?
Yeah. So 5G for me, coming back to Gus's point around scale, we've got some pockets of bits and pieces being done that are a kind of 5G level. We've got a couple of sites in the UK that are 5G, but actually it's about doing that scale piece and opening it up much more broadly. So moving into, you know, better imaging in video technology so that you can actually do diagnosis much better through video technology. It's about being able to capture these things in a much more secure environment with the speed that you have real time real-time patient monitoring in such a way that you can actually have all of those analytics going through, introducing analytics, so you've got machine learning, and that then steps into the preventative space, and that's really where we need to take this, is having introduced 5G, you enable all of those technologies, you push the care out of the hospital, so actually your future hospital, coming back to why we're here today, should be smaller in terms of people in it, but smaller in terms of people servicing it, and actually that care going out to the community, and that's what 5G will start to enable, and it's a massive, massive leveler in terms of access to care, and in fact, to be honest, it's actually not just care, is it, in terms of that ability to look at the whole person and what is causing, in the cases that you're talking about, the deprivation. So it's a great leveler in that sense of what we can all do.
Yeah, no, it's great. And actually, if you go down to the Vodafone downstairs in their booth, you'll see a great augmented reality display of the future hospital, the future healthcare system. You should go and see it. It's amazing on a kind of iPad projecting onto a screen. So do look at what they're trying to achieve and their thoughts around that. Priya, back to you now, because I think we talk about the UX and the UI in technology, the user experience, the user interface. What we're seeing now is actually the patient experience, which I call the PX, being now very much foremost in what we're doing. So has technology improved the experience of patients ultimately in your clinical practice?
So definitely through the Pulse Ox program in COVID, people felt we're very secure. We've also started remote monitoring our diabetics recently, and we did that in a group stage. We did it in a group consultation style. I have 5,300 patients in my surgery, 10.5% diabetic population. There's accessibility issues, there's language barriers. We brought all 10 of those people together with the language barriers, and we taught them the technology. And now they're actually monitoring their diabetes at home. They live in multi-generational households. Their families are supporting them in doing it. And actually their diabetic control, from what I can see, is starting to improve. So absolutely, I think it is. I don't think we should underestimate those with health inequalities either. I think we sometimes do that. They do have a lot of support. We just need to make it more accessible. And monitoring people who are at home and creating that preventative admission even is really, really important for these for elderly. And keeping people at home will make them live longer as well. And actually what we really need to do is start to empower our communities through technology. So the NHS can't do more. And that's physically where we are with capacity. So we need to start to empower our communities to do more for themselves.
Okay, that's interesting.
So therefore, they're starting to self-care, and we need to give the control back to them post-COVID, which I think they've lost a bit, which is completely understandable. Yeah. We know for example, as I said, 96% of my population's BAME. The BAME population was hit much harder in COVID. Yeah. The demand on primary care in my practice is unprecedented, and that's due to the rippling effects on these multi-generational households. So let's give them back the power. Yeah. Let's give them back the control that has been taken away from them.
Okay.
And I think we can close that gap with health inequalities if we use digital the right way, with the AI, with the analytics as well.
Great, so that's great examples. I guess that the thing to me at the moment is stickiness. COVID has allowed us to think differently, be more expansive, be more aggressive with innovation and implementation. But actually, we're seeing perhaps a decline now going back, though going out of COVID. That's a problem. So I'd love to ask Paul about the stickiness. We've come a long way. How do we stick at that level of saying we've done great innovation? How do we kind of propel ourselves on that basis from that level?
Well, I think what we have to do is we have to change our mindset, because if you just take the example there and just think about people in their own home and the issue of capacity in ICSs, you hear a lot about we haven't got enough bed capacity. Actually, if you take account that everyone's got their own bed in their own home, then we've got more than enough bed capacity. It's just our mindset is not about how do we maximize the potential for the individual to stay in their own home. How do we maximize the potential for the individual to self-manage? And we do have examples, so one of the things that's happening this winter is every single ICS is making sure that we're implementing virtual wards. Now, part of that is about providing monitoring support out into people's homes or care homes so that you can support people being in the home rather than in hospital. So we are starting to change our mindset, but I think that is the key to this, is actually, if you look at the capacity that we have from the perspective of what the NHS delivers, then you're massively underestimating the potential resource that we have. If we look at capacity from the point of view of how do we maximize the potential of individuals and how do we maximize the potential of people to live their own lives the way they want to, then actually the capacity we have is almost limitless. And the way to connect with that is through technology, isn't it? And then connecting the right clinicians to the right individuals at the right times by having the right technology to enable that.
Yeah, so it's been a great discussion. I'm going to open to the floor now as well for some questions. So please raise your hands. I'll come around and take my mic to you. If you just say who you are and then ask the panel a question. Thank you.
Thank you very much, panel. My name is Mamouna Rashid, and I have, so we have a startup based in Cambridge where we're working with ethnic South Asian patient communities. So my question is to Priya and to the panel overall around the inequalities and particularly digital exclusion. So we have been interviewing South Asian, particularly ethnic Bengali patients in East London, and we see an innate fear among many patients that gradually through this digitalization, NHS or primary care might be marginalizing them more and more. I was wondering that, I mean, you have given some amazing examples of how you're using digitalization and data to help patients. I was wondering, do you have any thoughts over there going forward in the primary care where things will be remote, things will be digital, we know that. How do we include these patients? You mentioned about empowering the community, so I would like to hear a bit more about that. Thank you.
Yeah, absolutely. I mean, it's the forefront. We would have really missed the trick if we don't bring our patients, especially our health deprived population. So Slough, 85% of 85% of Frimley's ICB deprived population lives in Slough. We have more than 150 languages spoken. And so we appreciate this problem quite at a very high level. So we've just started a digital bodies program. So we're working with the voluntary sector. For anybody that is struggling to use our digital solutions, we're buddying them up personally, one by one, tutorials. So we're trying to get the younger and older generations together to empower the older generation. And actually, we just did a focus group last Saturday. I was absolutely shocked. Most people want to enroll, so we're starting that, rolling it out. We're doing classes in A&E. If we're going to use digital solutions, we want care navigators in A&E supporting people to be able to use our services. We've gone to a place where all our GP websites are the same in all our practices. So if you are a patient and you're moving, which we have a very big transient population, the website's the same. So if you've learned it once, it comes all in different languages. So we're really thinking about our populations and how they use them. But I do think we do need to be careful. We do need to find solutions for these people, but we shouldn't stop digital innovation either. So if it works for 70% of our population, like we say, we should go ahead. And then we should work with these communities and co-produce with them to understand how we get them on our digital journey with us. So we don't always have all the answers, and actually they do. So we're working very closely to understand what our communities actually need.
Great, thank you. And the whole vaccination program in COVID highlighted the inequality. I mean, Tower Hamlets had the lowest uptake of vaccines. And I saw my GP colleagues walking door to door, knocking on doors with vaccines in their hand. It was really difficult to overcome that low rate of vaccines. Gus, any thoughts from your perspective?
Yeah, I think at the moment we've probably seen the largest inequality we'll ever see in our lifetime with COVID. So many people are waiting for healthcare at the moment. So I think digitization can really help, but you need to also be very careful that mindful that you don't sort of start to make big pockets of inequality, and that's my worry, is that actually we've got mass inequality at the moment because just generally getting access to healthcare is quite difficult. But going forward with digitization, you create big pockets, and it's addressing those pockets. There's some great solutions to be able to address that. So in France, as I said, the booth element, they go out to the communities. And in Leicester, for instance, we're talking to them about putting it onto mobile vans to actually go into mosques, go into temples, and actually have people who educate. So you can have better solutions, especially where you have deep pockets, because you can start to focus on those solutions. And working with your GPs in particular, I think the GPs will be the future hubs of care. I do think it needs to be moved away from the acuity element into community. 80% of expenditure happens in acute, 80% of care happens in a community. So that dichotomy has to move a little bit. But great question. It's a thing that I worry about all the time.
Sorry, I'll just add to that. So what I think Priya is also a great example of is actually that signposting and that collaborative effort. So for everyone where you've identified a key source of need, you're then signposting them to other organisations across the community, across the voluntary sector to pick up that piece. And I think another place that we've seen stuff like that in particularly working well is in Leicester, where you've kind of got these wellbeing centres where you're again bringing together those different organisations to address the whole person, coming back to that whole person concept. So I think that's
I mean, what ICBs have to be brave about is actually changing the resource of where the actual need is.
Yeah.
So exactly what Professor Shafi said. Slough, we got up to 80% vaccine. Then we knocked on doors. We got to 90%. We couldn't get that last 5%. But that last 5% cost us the most resource in trying to get people vaccinated. And we need to be really brave as ICBs to say, actually, hold on. If we focus on a small group of people, I mean 1,000. I'm saying really small groups of people, we will create resource for the population as a whole.
Great. So, Paul, that's a crazy statistic that GPs do 80% of the work, get about 20% of the budget. So next time you see your GP, remember that, okay? Don't give them a hard time. Paul, how are we going to solve that problem?
Well, that's been the enduring problem, I think, since the NHS was created, isn't it, really? And I think, it is fundamental to finding long-term solutions. Is we need to prioritise investment in primary and community services. And other countries that have done that see staggering results. So if you take Israel, for example, where they have focused on a primary care-led system, the transformation they've had there has been incredible. So although we do have a fantastic NHS, there's things we can learn from other countries. And I do think you're right. ICSs need to be brave about saying, because the pressure manifests itself in secondary care, and there's here and now pressure that has to be addressed. But the solutions lie in primary and community services. So we have to be brave to say, actually, we need to find ways of diverting investment or prioritising new investment in new ways of working in primary and community services.
Okay, great conversation. Any other questions? Yes. We'll come here. Is that okay?
Hello, my name's Gemma. I work for Capgemini. Paul, I had a question for you. Sorry. Really interested. You've all talked about virtual wards and the need to do more for people in their own homes. Given the national statistics about where we're at with the rollout of those virtual wards at the moment, obviously across your Midlands patch, how far would you say they are with rolling out those solutions? Do you think it will be something that will have an impact this winter?
Well, obviously, it'll be 100% implemented before winter happens. So that's no. I think the challenge with that is we're catching up with the fact that actually this is a necessity. It's not a nice to do. It's actually it should be an integral part of the way we work. So I think COVID did enable us to start working differently. And the way the health service transformed overnight under COVID in terms of embracing technology solutions was phenomenal. We need to keep the pace up with that. That's the reality. And I think the only way we're going to, I'll come back to the same point, I'm going to sound like a broken record, but I think the only way we're going to do that is if ICSs form genuine partnerships with digital-based organisations to really help them do that, because they can't do it by themselves.
Thank you. Another question?
Yes. Thank you. First, thanks to the panel for sharing all of your insights. I think we had a really great discussion around how digital could unlock more bed capacity, but what about for workforce capacity? What does that look like, especially at an integrated care level? What do you think ICSs could unlock, and what can digital unlock?
Can I just say one thing on that then, which you might correct me as a GP, but most GPs I talk to say to me that, you know, 1/3 of their patients should never have seen them in the first place. 1/3 of them could have been seen by someone else, and there's only 1/3 of them they really should have seen. So, you know, one of the things that we need to be able to do is better enable people to either self-diagnose or be supported to diagnose, so that and then connect them to the right person first time. If we're going to really be able to make best use of our workforce, we need all of our workforce to work at their maximum potential. And the reality is GPs are working at 1/3 of their maximum potential because they're seeing 2/3 of the people that potentially could be seen by the others. So there is something about how can we use the technology that we have and the opportunities we have to connect people to the right clinician first time.
Anne-Marie, yes.
Yeah, can I pick up on that one next? Jump on that one. So first of all, there's something around, coming back to the data piece, the bit that we'd all like to get to, which is absolutely pushing it further, even further back than primary and community, and saying we actually need to be much more in the preventative space anyway. So you're actually reducing that need. I think the right place, right time is really, really critical. And I'd encourage you to come and speak to me and Gus, because actually we've got some good ideas around that space, because that is a particular place where we need to work, isn't it? Yes.
Gus?
You want it now? No.
Okay. So again, in Frimley ICB, I think we're in a unique place where we have all the data sets in one place, so we can follow a patient's journey. And I feel very lucky, actually. So I feel personally, me as a clinician, feels we are at the turning point. We understand the movements of our patients. We can and what I think Paul's talking about, and what I call is the Amazon effect. The 1/3 of patients that we shouldn't be seeing is just the Amazon effect, and they can be seen by anybody. And I fundamentally do believe that can be done at scale. But on the flip side of it, for example, in our Frimley data, I'm very, very data-driven and population health data-driven. We only have 7,000 heart failure patients in 850,000 patients. Why are we doing it at 78 different practices? Why are we doing it at 2 different acute trusts for 7,000 patients? So for me, I think it's really about understanding the population we're serving, what ethnicity they are, what are their barriers to health, what's their accessibility, and actually creating teams, cultures around our people, rather than trying to get our cultures and teams to work for our people.
Gus?
I sort of mentioned earlier on that I think we could give back about 20% of time to colleagues in the sort of clinical healthcare. And over the next 12 months, Deloitte and Vodafone are going to launch a series of ideas. First idea is the digital service. So what can we actually digitize in terms of services? There's a fabulous technology, Content Guru, who provide a platform to actually so that people can route calls in to a larger call center, and they can start to use bots, booking systems, processes that can really reduce radically the amount of time people spend on pen and paper taking calls. These are technologies that banks, insurance industries, all those industries have introduced about 10 years ago. They're already here. Why are we not using them at scale? Then we can give all that time back to caring the right areas. There's loads of processes. There's a fantastic platform that does manages and logs sickness and absence. We've got hundreds of people throughout, nurses all the way through. Actually, that can just be done on a digital platform. It's £2 a year, 24/7 for one person. That's a digital. So these are the sort of digital services that we need to create, and there's loads of them in the marketplace. It's just that the NHS has been slow to adopt because it's going from one crisis to the next. Actually, Vodafone and Deloitte, with all the sort of networks that we've got, we're going to start to bring that through. So I think we can really radically transform things there. And the second element is the agile clinician. So there's loads of technologies that we can bring together. I think we've got here today, we've got Total Mobile, Alertive, the Lone Worker. We've got asset tracking programs. You put all those together, again, you could release up to 15-20% of people's time back to care. These are all ideas, and unfortunately, I'm a consultant by background, so I just go and copy loads of other good ideas and bring them and badge them slightly differently. Yeah. What was it? This is your watch, isn't it, Anne-Marie? I'll tell you the time. So these ideas are already there. They're already proven, so we're not bringing any new innovation. There's some fabulous new innovation that we're talking to. There's a great company that does an avatar at home, looks after people at home at the moment. Fabulous. It's used in other Far Eastern sort of countries. It's not used in the UK, but that could radically change healthcare at home. So there's some fabulous ideas. The idea for Vodafone and Deloitte is to really bring that through over the next few years. So that's how we can address some of the things around workforce, which I'm hugely excited about.
So I think that's really clever, isn't it? We have a huge problem with workforce. How do you overcome that? Actually, listening to what Gus is saying is thinking slightly differently, different digital services. Some of the companies that they're working with, for example, might provide a solution that's outside our thinking box, not about replacing human with human, replacing automation processes so that clinicians can do their job in a better way. We have time for one last question. That's okay, panel?
Thank you. I'm Peter. I'm the master's student at GBSH, UCL's GBSH. I'd like to circle back to the gentleman's points in the beginning of the floor opening around health equalities. Priya, you mentioned that you're very engaged with the community in your vaccine uptake. I mean, 85% in the BME community is great. But when you're trying to implement this integrated care system and empowering the community to use their own beds, for example, or as they say, use their own beds for open up capacity in hospitals, how are you going to engage the communities that are facing these inequalities, such as ethnic background and generational categories? How are you going to engage them and empower them to essentially trust these companies, such as the NHS, such as Vodafone and Deloitte, with their data, with their like their notions, their preconceptions, their rumors, perhaps? How are you going to build onto that trust? Because yesterday, one of the talks, there's a charity that uses that gives out the devices to the older generation to engage with digital health, but one of the people that goes into those communities, they have to take off their NHS badge to show that, okay, I can be trusted. Once they put it back on, some of these communities feel a bit worried about that. So yeah, again, that 85% is great, but when you're trying to nationalize it or bring it to a larger scale, how are you going to bring forward that trust? Because you can't go to every single door around the country to implement that. So I was just wondering, what are your plans for that, especially with Vodafone and Deloitte? What are your plans to build that trust with those communities? Thank you.
So trust. Would like to take that on? Priya?
Great question. I don't know if I have the answer. At the moment, it is knock on everybody's door. That's what we're trying to do, because we know where these people live and we're trying to gain that trust. So, for example, we have a deprivation questionnaire. We've gone out, we've asked 2,000 of our individuals. That's been done through health. But 1,000 of those individuals we approached declined us. So we have a long way to go with these individuals, but the 2,000 I've helped, I hope I've changed my relationship with them. I've got food for them, not me personally, but I've worked with my teams to get food. We've worked with Citizens Bureau. We got a house. Someone was living in their car with their 3 daughters. And by us actually approaching them in a different way, what's actually shown in the data is they're engaging in health in a different way. They're coming to their health checkups because we've helped them with their needs. And I think that's what's fundamentally changed for me. Before, I used to do a consultation with the patient. I'd be like, you've come in with abdominal pain. Tell me about your abdominal pain. My whole thought process is now, actually, what's causing your abdominal pain? Is it the fact you can't put... And we need to change that. And that's a 5 to 10 year journey. But I fundamentally believe if we put our people's needs first, we've been putting health first. We've got to put the people's needs in front of us first. And then we'll gain their trust and we'll get much further in the health system.
Yeah, I agree. So back to trust for Anne-Marie and Gus, of course, because we could spend a whole day talking about data. Honestly, I don't think we have time to discuss that big conundrum that we have going forward. But Anne-Marie and Gus, trust, so key.
So I think for me, in terms of large companies, that is about leading by example. So yes, it's fabulous to see what Priya is doing and literally that knocking on door stuff. I would like to think there's also a kind of generational pull. My nanny would have referred to herself as a silver surfer when I tried to teach her what she was doing. But also from the point of view of just big organisations, I would use the example of our connected living work, Shafi. So where we were working with MenCap to develop an app, basically, that could be used in lots of different environments that would help with frail elderly, but help with those with learning disabilities, that is to help sort of everyday household tasks made more easy. So whether that's through visual aids or diary scheduling or whatever it is, lots of different ways in which you can help with those tasks. Very practical, hands-on examples of large companies being able to do that kind of thing in a specific environment. And I think I would like to see more of us, doing those sorts of things, but joining up better with those in the community and in primary care to help get that kind of education, awareness of us as big suppliers and of those who need that help.
Gus, you've had a lot of experience in trying to adopt change across hospitals and things. What are your thoughts about the trust element?
Yeah, it's probably the biggest thing in my career, to be honest with you. We like to make sure we're the trusted advisor. I have relationships going back decades, and yes, I am that old. I do have relationships that go that back far, and trust is hugely important. As Vodafone and Deloitte, we've spent the last 12 months talking to people. We've done surveys across 4 different countries. We've talked to thousands of clinicians, thousands of patients to really understand what the big issues are. Data sharing, privacy, big issues for all of us. All the people in our ecosystem have to be 100% compliant with all of those. They have to be ethically sort of monitored from our point of view. We've seen some great texts here today. They're not compliant with quite a few of the things that we would want. So we have fairly high standards from our point of view. So so you've got all these stepping stones that you build up to make sure you can get to that trust level. And it's fundamental from our point of view. We then make sure we listen to the patients, to the clients, to make sure we're taking on board, okay, I might trust you now, but I've got all these other concerns. So inequalities, for instance, is a huge thing. We worked on the Leicester vaccination program. We set up camps in parks. We went out to all the sort of religious centres. It's listening to make sure we can get to those particular points. What we don't want to do is have a 2-tiered system where one side of the population is very well served and the other is totally ignored. That's not what we're trying to do. I'm quite excited for the future in terms of healthcare because I think we're going to democratize it. I think the NHS could be the next Amazon, in terms of personalized healthcare. Look at all the other sectors. They have gone to personalized healthcare, and I think we can do that increasingly. I can't get my youngest one off her phone. She speaks to me, does 3 other things on her apps. They're all very sort of capable of doing various things, but that's the future. And actually, I think we could democratize healthcare to the masses, and that's what really excites me going forward. So your question of trust is probably the number one thing for us, and both our brands are built on trust. We have huge amounts of investment in that particular area.
Thank you. So you heard it here first. NHS is the new Amazon. So go and buy those shares tomorrow when they go private. I'm just kidding, of course. What a great conversation. I'd like to thank our esteemed panel, Paul, Priya, Anne-Marie, of course, Gus. That's worth of knowledge experience, all in 45 minutes. Thank you so much for your collaboration, asking the right questions. And applause for our esteemed colleagues. Thank you so much.